Okay, hello and welcome everyone to our webinar Wednesday in recognition of Testicular Cancer Awareness Month. As a reminder, for those of you who are joining us live on our Zoom, please make sure that your microphone is muted when you're not speaking. We are streaming this live to our Facebook page, and it will be recorded and put on our YouTube page as well. So feel free to turn off your camera if you prefer it that way. And remember that we have the chat box. If you have any questions throughout the presentation, you can use the chat box function on Zoom to ask questions. We'll also have some time for Q&A, so you can also unmute yourself if you want to just ask a question directly. For those of you who are joining us on Facebook Live, please use the comments section to ask any questions that you may have throughout the presentation today. The Webinar Wednesday series is brought to you by the University of Chicago Comprehensive Cancer Center, Office of Community Engagement and Cancer Health Equity. We are the bridge between University of Chicago cancer researchers and the communities that we serve, both in and around Chicago. So welcome. We are so excited to be able to bring the cancer expertise of our clinical and research faculty at the University of Chicago to a broad audience. My name is Poulos, and I am an education outreach specialist in this office. I'm also joined by our Director for Community Outreach and Engagement, Gina Curry, and our Latinx Outreach Specialist, Erica Rodriguez. They're on our call today, so you can feel free, if you're joining us on Zoom, to message any one of us if you have anything that you'd like to ask about our office directly. Our speaker today is University of Chicago faculty, Dr. Parth Modi, and I will let him introduce himself and sort of share his background and his expertise, and he'll be speaking to us today about testicular cancer. And Dr. Modi, I've stopped sharing my screen if you would like to share yours now.
Okay. Well, good afternoon, everybody. My name is Parth Modi. I'm a urologist and urologic oncologist, an assistant professor of surgery and urology here at the University of Chicago, and very excited to talk to you all today about some of the basics of testicular cancer. So I'll launch right in, but please feel free to send in or jump in with any questions that come up along the way or afterwards. I'm happy to address any questions that come up that I don't get into. Testicular cancer is a complicated topic, and I like to start off with just some of the basics. And so the first thing that we need to cover is basic anatomy of the scrotum. So in this diagram, you can see again depicted the testicle, which is the round structure in white. The testicle is responsible, obviously in men, for two main functions. One is the generation of sperm, for reproduction, and second is the generation of testosterone, the male hormone. Second, here you see the epididymis, which is the start of a tube system that carries the sperm from the testicle to the urethra and to the penis for ejaculation. There's also the spermatic cord, which is, again, more of that cord structure that also carries blood vessels and the blood supply to the testicle. And finally, coverings or fascia, layers surrounding the testicle. So the testicle, in our embryological development as fetuses, develops really back near the kidneys in the retroperitoneum. And as we develop in utero, it travels down by the kidneys all the way down into the scrotum. And along the way, it picks up several layers of coverings. And that's also important in the anatomy of the testicle. So before we get into talking about testicular cancer in detail, I want to talk about a few things that often can be mistaken for testicular cancer, but is not testicular cancer, other scrotal abnormalities that are often seen. And one of the most common, is called a varicocele. And a varicocele is a collection of dilated blood vessels in the scrotum. And the diagram here sort of depicts this on the left side. And this is really much more common on the left side than the right side, but it can happen on either side. And it's essentially the equivalent of varicose veins, but in the scrotum, with veins related to the veins that drain the scrotum. This can have implications for fertility. It can have implications for pain or discomfort, but this is not cancer and is not related to testicular cancer at all. Next is something called a spermatocele. A spermatocele is, again, a cystic mass of the epididymis that can be often felt if you do a self-exam of the scrotum. and it's a cystic structure that's full of fluid and sometimes sperm. This is often not treated at all. Sometimes they can get large or cause some soreness or discomfort, and we can surgically remove them. But this also is not cancer and is not sort of pre-malignant or a risk factor for cancer, as far as we know. There's also something called a hydrocele. Hydrocele is a collection of simple fluid around the testicle. So as I mentioned, those coverings that the testicle acquires as it travels down into the scrotum, sometimes within those layers, some fluid can collect, and this is called a hydrocele. This is something that many men have, and it's a benign entity as well, not cancer. And these can grow to be quite large, and we do sometimes do surgery for these as well. But again, this is not cancer, and it's not considered to be a risk factor for cancer. And finally, testicular tumors, which are often testicular cancers, they are sort of distinct from the entities that I mentioned before in a few ways. First of all, these arise from the testicle itself, not from any surrounding areas in the scrotum. These are often almost always painless, meaning that men with a testicular cancer or mass don't necessarily have testicular pain or scrotal pain, but they do feel, if they do an exam or touch the scrotum, they could often feel a hard or a rock-like tumor or mass in one of the scrotum, one of the testicles. So how do we diagnose testicular cancer? Well, the main test that we use initially is an ultrasound. And so this is a picture of a normal testicular ultrasound. So as you can see here, this oval object is the testicle. It has a nice, what we think of as a homogeneous appearance. Everything looks kind of the same. And there are distinct borders of the testicle. This is essentially a normal looking testicle on ultrasound. Here are a few examples of abnormal ultrasound pictures. And so on the top left, you see the testicle, which looks pretty normal. And then just to the left of it, you see a large dark area. So this is a spermatocele. And the large dark area is that cystic structure of the epididymis, which sits outside of the testicle. On the top right, you can see an ultrasound with something called Doppler, which is a color image that shows flow. It shows the movement of stuff on the ultrasound. And in this case, what we're looking at movement is the movement of blood in large veins around the testicle. So this is a varicocele, which is again that entity that I mentioned at the beginning, large dilated veins around the testicle. On the bottom left, you see a hydrocele. So again, you see the testicle itself. It looks pretty normal. There's homogeneous appearance. It looks all the same. But around it is this large dark area. And dark on an ultrasound is fluid typically. And in this case, it looks like simple fluid. This is what I described to you all as a hydrocele. And finally, on the bottom right is an ultrasound image of what would be considered a classical picture of a testicular tumor. This is, as you can see on the sort of bottom right part of this testicle, sort of heterogeneous appearing. So there's heterogeneous meaning a different appearing. There's areas that are light, areas that are dark. It's not all consistent in the way that the normal testicular ultrasound picture was. And so ultrasound of the testis or ultrasound of the scrotum is one of the most common diagnostic tests that we get for patients with a testicular mass. But how do we even know who to get an ultrasound in? Well, this is where young men come in. We recommend that men do a monthly self-testicular exam, a scrotal exam. This is often done in the shower. It's really very simple. You hold the scrotum with one or two hands, use the fingers behind the testicle and the thumb in front of the testicle, and just feel the testicle, understand what it feels like. And this is really recommended for all young men to do initially to understand what their normal scrotal exam is, and then over time, if something changes, it'll be more easy for somebody to pick up for himself by doing this on a regular basis. If you do feel a mass or something in the scrotum that's unusual, it's different, or just doesn't feel right, it's very important that you see a physician or a urologist specifically to be examined and to potentially get an ultrasound to make a diagnosis. There are a lot of things that a lot of abnormalities on a scrotal or testicular exam that are not necessarily testicular cancer, but it's important if you feel something unusual or that you're concerned about to see a physician and get checked out. So a little bit about the epidemiology of testicular cancer. This is a curve that shows the ages at which testicular cancer is diagnosed. And as you can see here, testicular cancer is really a disease of younger men in general. and tends to occur most often in the middle, younger ages, in the 20s and 30s, and sometimes 40s. So this is the traditional distribution of age for testicular cancer. And what are some risk factors for testicular cancer? Well, there's a few well-defined risk factors. So one is undescended testicles. So we know that men or boys who have had an undescended testicle are at a higher risk for testicular cancer, and that risk persists even if the undescended testicle is fixed or repaired or brought down into the scrotum. Number two is a family history of testis cancer. So father, brothers, uncles, male relatives with testis cancer certainly increases the risk, as well as a personal history of testis cancer. And this may not be surprising, but if a man has testicular cancer on one side, his risk of having it on the other side is significantly higher. And finally, intratubular germ cell neoplasia is a precancerous lesion of the testicle. And this is typically found on a testicular biopsy if one is undergoing that for some reason, often for infertility evaluation. And finally, infertility, not necessarily a risk factor in the sense that infertility causes testicular cancer, but we know that many, many men, more than in the normal population who have testicular cancer, do have subnormal fertility or less than normal fertility rates. So what do we do once we find, a patient finds a mass or an ultrasound suggests that there's a mass in the testicle that's concerning for a testis cancer? Well, in almost all cases, the next step is to remove the testicle. And we do that with a procedure called a radical orchiectomy. And orchiectomy is just a fancy word for removal of the testis. And we don't do that by making an incision in the scrotum, but in fact, we remove the testicle with a small incision in the groin, as you can see depicted here on the figure. This is another sort of diagram of that operation. And here again, as you can see, we make a small incision in the groin, in the inguinal region, deliver the testicle out of the scrotum, and along with the spermatic cord, which is that attachment of the testicle that carries both blood vessels as well as the vas deferens that carries sperm, and we divide and remove the testicle and the spermatic cord in its entirety for treatment of the testicular mass. And then that entire specimen, the testis, the spermatic cord, all gets sent to pathology. The pathologist looks at it under a microscope and does various tests to give us give us an answer about what kind of a mass is it. Is it cancer or not? If it is a testicular cancer, what kind is it? Many men ask about testicular prosthesis. Can we replace the testicle in the scrotum to make it more normal? And the answer is yes, we can. We have these prostheses. They are 100% cosmetic. There's no function of these small sort of plastic inert testicular prostheses. They're full of saline. And often men don't want this or aren't interested, but it is an option. We do have it available if there are men who want to do this for cosmetic reasons at the same time as we remove the testicle for testis mass. So what happens after we do the surgery? Well, if we do the surgery and we find that this is in fact testicular cancer, there's a pretty standard evaluation that we'll do, and that involves really two things. Number one are tumor markers, which are blood tests. So testis cancer is well known often to produce certain chemicals in the blood, which we can pick up. And those are the three that you see listed here. AFP stands for alpha fetoprotein, beta HCG, and LDH is lactate dehydrogenase. So these are three circulating markers in the blood that we follow after surgery and going forward to detect any recurrences of cancer. In addition, you'll get CAT scans or imaging tests, pictures of the chest, abdomen, and pelvis. And the reason for that is often with testis cancer that spreads, it tends to spread primarily to lymph nodes in the retroperitoneum. The retroperitoneum is the part of the body that's in the abdomen, sort of near the back or behind all of the bowels and intestines. And lymph nodes in that area tend to be a site for the spread of testis cancer. And so a CAT scan of the abdomen and pelvis is absolutely needed to make sure that there isn't any spread there, or if there is, to understand how much there is. And similarly, a CAT scan of the chest, because testis cancer can also spread to the chest and the lungs. And the last part of the evaluation or the staging is to understand what type of cancer it is. And this information really comes from the pathologist when they examine the tissue from the orchiectomy. The two main kinds of germ cell tumor or testis cancer is seminoma and non-seminoma. And these happy to go into in more detail. And there's also other more rare types of testis cancers. So understanding what type it is really essential for understanding what the treatment options are. So once we collect this information after surgery, we assign a stage. Typically, in very broad strokes, we can say that the stages are 1, 2, and 3. Stage 1 of testis cancer is when the cancer is confined to the testicle itself. Stage 2 suggests that the tumor is spread to lymph nodes, most often in the retroperitoneum. And stage 3 is when testis cancer is spread to other organs, and that can be the liver, the brain, the lungs, or others. So what do we do to treat these cancers? Well, let's start with the stage 1. So stage 1 is testis cancer that's confined to the testicle. And in that case, again, the treatment really depends on the histology of the cancer. So is it seminoma or non-seminoma? But broadly, there are really 4 options. The first is surveillance. So for many patients with testis cancer that's confined to the testicle, simply removing the testicle is enough to cure the cancer. And for all men, even if we believe that the cancer is cured by that surgery, close surveillance is necessary. And that means CAT scans periodically, blood tests to check those tumor markers, and a physical exam of the other testicle and of the patient in general is needed at fixed time points over the next several years. Another set of options is chemotherapy. Well, again, if stage 1 cancer means we think that the cancer is confined to the testicle and we remove that testicle, why chemotherapy? Well, we know that there is a chance, and depending on the specifics of any given tumor, we can be more specific about the risk, but there's a risk of microscopic disease outside of the testicle that we just can't see on a CAT scan. And chemotherapy reduces the risk of that cancer coming back by some amount. And that's a discussion between the patient and the oncologist about whether it's worth considering chemotherapy. A similar option for some kinds of cancer is radiation therapy. Radiation therapy can be used also to prevent the recurrence of the cancer, even if it's unlikely to recur. And finally, surgery. So surgery, again, is another option that we sometimes use, less often now in stage 1 cancers, but it is an option to remove the lymph nodes in the retroperitoneum, which are the place where the cancer tends to recur or spread to. So to give a little bit more detail, this is a diagram of the retroperitoneum. The retroperitoneum, again, is the area of the abdomen that's behind the intestines, around the large blood vessels. So here in blue is the vena cava. In red is the aorta, the sort of main blood vessel highways of the body. And around those structures in the kidneys are a lot of lymph nodes. And lymph nodes are part of the body's system of capturing, detecting the spread of cancer. And these lymph nodes, we know, tend to be the most common places for the spread of testis cancer. And so for patients who do undergo surgery or radiotherapy, radiation therapy, the radiation therapy is directed at these lymph nodes in the retroperitoneum, or surgery would be to remove these lymph nodes in the retroperitoneum. And traditionally, that surgery, which is called an RPLND, or retroperitoneal lymph node dissection, is done using an open incision, as depicted on the left side, a midline incision, so an incision sort of in the middle of the abdomen, going from above the belly button to below the belly button. More recently, in select cases at certain expert centers, including the University of Chicago, we can perform this surgery using the robot. Surgical robot is an instrument that the surgeon uses to perform the same surgery, but in a minimally invasive fashion. So instead of one large incision, we use 5 or 6 small incisions, as you see depicted on the right side here, to remove the same amount of tissue and lymph nodes as we would do with a bigger open incision, but typically with less pain and a faster recovery. What about for more advanced testis cancer? So if the testis cancer is not confined to the testicle, but has spread to lymph nodes or other organs, then the mainstay of therapy is really chemotherapy. And I want to emphasize that the development of really good chemotherapy for testis cancer has been a real amazing benefit to testis cancer patients over the last many years. Testicular cancer is very curable. Even advanced testis cancer that has spread to lymph nodes or other organs can be cured. And the reason is very effective chemotherapy. And so the most common chemotherapy regimen includes 3 medications that you see here: bleomycin, etoposide, and platinum. But there are additional chemotherapy options, even if those 3 fail in the second and third lines. And again, testis cancer is somewhat unique in that its survival rates and cure rates, even with very advanced disease, is extremely high. So this is really good news for our testis cancer patients. A common concern for men with testicular cancer is fertility. And as I mentioned earlier, there tends to be a correlation here that about half of men who are diagnosed with testis cancer have less than normal fertility or have low sperm counts to some degree at the time of diagnosis. In addition to that, we know that surgery for testis cancer, radiation, and chemotherapy can all have a negative impact on fertility. And so for that reason, for any young man with testis cancer who might potentially be interested in fertility or having children in the future, for those guys, we recommend sperm banking or sperm cryopreservation just to maintain that option before we do surgery or radiation or chemotherapy for testis cancer. We'll move now to some frequently asked questions. I sort of addressed the first already. Can I father a child after testicle removal? The answer is almost always yes. The other testicle can do the job needed to produce sperm for fertility. As I mentioned, many men with testis cancer already have less than perfect fertility for other reasons that we don't fully understand. But that said, removal of one testicle still leaves another testicle for most guys, which will be more than enough for fertility. Similar question, will my testosterone go down? What's the effect on erections or libido? So the second function of the testicle is, of course, to produce testosterone. And for almost everybody, a normal second testicle will produce all the testosterone that the body needs almost immediately after after one testicle is removed. The other one picks up the slack, so to speak. And so erections and libido can be expected to be essentially normal. Is there any way to prevent testicular cancer? Well, as I mentioned the risk factors earlier, none of those were really behavioral or modifiable risk factors as we think about them. So as far as I'm aware, there's no really good way to prevent testicular cancer. The main thing I want to emphasize is early detection is really key. And so self-exam young men in the shower at least once a month is a good idea and strongly recommended. And many people, when we talk about chemotherapy, ask about natural therapies or remedies that can be used that are less toxic than chemotherapy. And the answer really is not that are proven to work. There are not really natural therapies that will prevent or treat testis cancer. But the good news is chemotherapy, despite having side effects, is extremely effective, even for very, very advanced testis cancer. And that's really great news and one of the things that makes testicular cancer unique among cancers. So I'm going to stop there and open up the floor for any additional questions. I'll be happy to address. And thank you for your attention.
Thank you so much, Dr. Modi. Are you all able to hear me right now? My Zoom is frozen. Oh, great, thanks.
We can hear and see you, yes.
My Zoom is totally frozen. Dr. Modi, can I ask you to just stop sharing your screen for a second? I think that might be, this is the second week in a row that this has happened now for me, and I'm not quite sure why.
Yeah, I've stopped the screen share.
Great, thanks. So let's see. So my Zoom is still frozen. So if you do have any questions, if you want to ask an anonymous question, I'm going to say if you could send that to my colleague, Erica Rodriguez. She can monitor that better than I can because I think I can't, nothing's really moving on my Zoom. But I do have some questions here for Dr. Modi. And also, too, you can feel free to just unmute yourself and ask directly if you have a question. So you talked, Dr. Modi, about how testicular cancer is more common in younger men. Do we know of any other racial or ethnic disparities in terms of who is more likely to get testicular cancer?
We do. There are geographic disparities in terms of the part of the world that you live in, but also in the US, I believe the most recent data suggests that white men are more likely to be diagnosed with testis cancer than Black or Hispanic or Asian men.
Oh, okay. Interesting.
Okay, I had someone ask, what are the survival rates for men ages 24 through 35?
The survival rates for almost all men with testis cancer are in excess of 95%. As I said, even men with advanced cancer have a very high chance of long-term survival with appropriate chemotherapy. So the survival is very, very good for testis cancer in general.
Okay, so I understand you mentioned the importance of early detection. Now, what are some of the symptoms that would give a person an indication that maybe they that they may be having an issue?
That's a great question. Unfortunately or fortunately, there are not really symptoms. As I said, typically a testis cancer doesn't cause pain. It doesn't cause any trouble with urination. You wouldn't necessarily notice any change in sexual function. The real symptom is feeling a hard mass in the scrotum on examination. So if you don't examine your scrotum, it can be difficult to identify a testis cancer from any other symptom. There really may not be.
And along those lines too,
sorry, Eric, I hope I didn't cut you off. I just switched headphones. I got all kinds of tech problems over here. So along those lines as well, and I think, this is probably something you would have mentioned. At this point, there doesn't seem to be any kind of like preventative screening besides, nothing like the equivalent of a mammogram or anything like that, besides just making sure that people do self-examinations at home.
Yeah, that's right. There's no other screening that's really shown to be effective or recommended for testis cancer. Regular self-examination is sort of the screening, and like breast self-exams for women, testicular self-exams for men are very effective. Probably because the testicles are easy enough for a man to examine, there's no need or recommendation for any kind of ultrasound or mammogram or X-ray type of test.
Great. I have a question here about, are there any identifiable genetic or hereditary markers for being predisposed to testicular cancer? I know that you had mentioned, if a family member has it, you're maybe more likely, but is there any sort of genetic testing or genetic marker of any kind that would indicate that someone's more at risk?
There isn't any that I'm aware of. Now that research is ongoing all the time, and so there can be, changes to that. But as far as I'm aware, while we know that there's a family history as a risk factor, there haven't been any specific genetic mutations that have been identified that we could look for example, as an early marker.
Is there any way to remove the tumor without removing the entire testicle? Some sort of like a lumpectomy? And again, I'm sorry, I'm comparing this to frequent, frequently used terms in other cancers, but is there any way to do that without removing the whole testicle, or is it really just the whole thing needs to go?
There is such a thing as a partial orchiectomy, or removal of a portion of the testicle. That's done quite rarely and in very select circumstances. As always, we want to balance preserving functional normal testicle with doing the best possible job from a cancer perspective in eliminating the cancer. And so many testis cancers are not appropriate for that kind of surgery, but in specific select circumstances, we can do what's called a partial orchiectomy, or removal of just part of the testicle.
So Dr. Modi, you mentioned that this is something that typically someone between the ages of 20, 30, early 40s may somehow experience. What's the youngest you've seen that's come in?
Well, for the typical kinds of testis cancer, it can occur in teenagers, 16, 17, 18 as well. There are other types of testis cancers that are more common in younger kids, 3, 4, 5 years of age, but that's typically of a different type of testis cancer. But for these that I mentioned, in general, seminoma and non-seminoma, the germ cell tumors, I think the youngest patient I've seen is 15 or 16. Okay. So, I think after puberty, regular self-exams are a good habit for all boys and men.
Okay, thank you.
That's really interesting that you said that. I wonder too, this is just making me wonder out loud if that's something that's covered in, health education classes and sex ed classes in schools. As someone who never went through the male equivalent of that, I do wonder if that's something that's covered, and that's something that we can, do a little education around for some of our health educators out there.
Yeah, I think it is. It's been a number of years since I went through that myself, but I think many schools and health education groups for teens and young men have adopted that.
That's great.
But certainly that's a great idea for some additional outreach.
That's great. And then I have a question here asking about, so is there any other, does testes cancer have any effect on on sperm at all, on the remaining sperm, besides obviously if you are removing a testicle, that'll certainly you'll probably have less sperm, but is there any, I guess, effect on the sperm, on the remaining sperm?
It's a good question, and it's a little bit complicated. So part of the reason it's complicated is the idea of cause and effect. We know that men with testis cancer also tend to have abnormal sperm parameters. It's not clear, though, that one causes the other. It may be that whatever problem is causing the less than perfect fertility or the abnormal sperm, whatever that causes could also be causing or increasing the risk of the testis cancer. So it is common that those two things go together, but it's not clear what's causing what. One thing we have identified is that often after removal of the testicle with the cancer, the overall semen parameters or sperm parameters actually can improve, and fertility can improve after the removal of the testicle with the cancer. So that's another possibility, but no, there isn't any known cause there per se. And it's normal to expect after the removal of the testis with the cancer that if the other testicle is normal, that normal or very close to normal fertility can exist after that.
Oh, it's good to know. So I don't have any other questions here, and I can't see the chat box. Erica, are there any other questions coming in through the chat box?
No other questions.
Okay, I'm going to do a quick check on our Facebook Live, and if anyone else on our Zoom has any other questions for Dr. Modi, please feel free to unmute yourself and just ask. Okay. And what I'm going to try to find for everyone, I tried looking for this earlier, but I think the settings on my YouTube were such that I couldn't find a video about the self-examination at home, because I know that Dr. Modi had brought up that was a really important way to try to find and prevent advanced testicular cancer. So I will try to find a video on that. I think I've got to change some settings to allow that kind of video to come up on my YouTube. But Dr. Modi, is there anything else one big takeaway that you'd like to leave for our viewers today?
Yeah, there are a lot of good resources online and a lot of advocacy organizations. Cancer.org is the American Cancer Society has good information, but there are a number of testicular cancer advocacy organizations. I think the message I would want to leave everybody with is that young men after adolescence should do regular testicular self-examination, and if there's a concern or something abnormal or something that's changed and doesn't feel the same, to definitely seek advice from his physician.
And I'm so sorry, I have one final question that just came through. It says, are there any other conditions which predispose a person to testicular cancer, as in testicular torsion?
It's not clear that testicular torsion is associated with testicular cancer or causes it. No, I don't think so. So, I think the risk factors that I mentioned are the only ones that are really well established. But research in this area is always ongoing.
Okay, thank you.
Great. Well, huge thank you again to Dr. Modi for taking time out of your day today to share your expertise and your wisdom with us and answering all of our questions. This was a lot of great information. I feel like testicular cancer is one of those that maybe doesn't get as much airtime as some of the harder hitters like breast cancer and lung cancer and that. So this is a really great way to raise some awareness about testicular cancer and about what people can do to hopefully catch it early and prevent it from becoming a more serious problem. So thank you so much again for being here with us today and speaking with us.
My pleasure. Thanks for having me.